you have to let them in? I don't know how that works. I'm still, after 6 months into Zoom and Microsoft Teams, I still don't get how it works.
So we are live, and so we're live streaming on YouTube.
Oh, I see. I see. Okay.
So they'll ask their questions on there in the chat feature.
Okay.
And we are live now. Good afternoon,
Okay.
everybody.
All right. Hey, Jasmine and Dr. Cho, thank you so much for joining us today. Looks like we have 40 or so people on the live stream right now. So good afternoon, everyone. Please put in the comments that you can see and hear us okay. Make sure we've got that going. And then, okay, got a couple comments saying hello. So it looks like we're working okay. What I'll do is the normal deal where I just go through sort of where we are with, okay, Hendoga says he can hear us good. So we'll just go ahead and share the graphs and talk about just sort of where we are. So let me get this up real quick. Okay, so here is a graph I like to look at. Talking about sort of where we are. This is, oops, Pasco, let me get us to Pinellas. So here's Pinellas. You can see the big spike we had continues to come down. That plateauing that we've talked about has continued, and we are seeing just a little uptick here in percent positivity. Overall numbers, though, remain reasonably low, but clearly not as low as they were back here. The interesting things that I'm looking at this week is the fact that Pasco County has a significantly higher percent positivity rate, over 5, and Hillsborough County also remains over 5. So although Pinellas specifically is doing pretty well right now, our neighboring counties do seem to still have higher rates. Also, I think at a sort of overall nationwide view, we're beginning to see what could amount to a second uptick. And I will pull up a graph here, hopefully, that I can show you guys. Here it is. And this is kind of what concerns me, is this was where we were in the beginning. This is the spike in early March and April. You saw we came down. We never came all the way down, but we came down a bit. We all kind of started doing reopening stuff here. And then boom, we had the big one. Now it's come back down again. And we're kind of right here now. And yet we're already starting to do reopening stuff. So we haven't even made it back to the pre-July spike baseline, let alone the pre-March spike baseline. And so if you were a person who likes to look at graphs, you would say, well, if we went like this here and here, the natural extension of that would be up to here for the next one. And if we were really close to stressing out the healthcare systems here, where will we be here? So that's what's really concerning me right now. So I know we've gone to phase 3. I know there's a lot of folks who are really wishing this was over, and I'm among those people. I really do. I can't say that I think it's really over at this point, and I would say that we still need to be very cautious about any prevention activities that we're doing to try to keep these numbers as low as possible and minimize the impacts. As far as actual folks in the hospital right now, remembering as always that this is a lagging indicator, we do have just over 100 people hospitalized in Pinellas County with COVID still, with about 20 of those in the ICU and about 13 of those that are in the ICU vented. So we've seen this fairly consistently with somewhere between, around a quarter, ballpark now it's about 20%, but around a quarter of the patients being critical in the ICU and about a half of those patients being intubated. And that's where we've been sitting for several weeks right now. So that's kind of it. I do notice on the daily admissions versus discharges of the hospital that for the last couple of days, admissions have outpaced discharges by just a little bit. So I know certainly I'm continuing to see COVID patients in the ER that I work at. And so I think we're still seeing that on the ambulances or on our 911 calls as well. Jacob, I'm not sure I know what you mean by not a stock graph. So I'll take any questions there about just sort of general situational updates where we're at. Nothing changes at this point in terms of universal PPE on every call. And we're going to continue that for the foreseeable future. Let's see if Jacob can clarify his comment. Okay, so I'm not seeing any other questions about sort of the situational update right now. We do have about 50 people watching currently, so that's great. Please feel free to put your comments in. We'll try to address them as best as we can. Oh, Jacob meant like stock market graph. It would be nice if the stock market was going to climb like that. I get it now. Yes, it would. Okay, here's a question coming in. So COVID-19 and influenza. I know it's a big, rough question. Dr. Cho, what are your thoughts on public safety management, tracking, compounding clinical factors, treatment, and care? So I'm going to hold off on that for 1 second because I didn't even really get to introduce Dr. Cho yet. Okay. Chief Burford asks, is your advice to continue the wellness checks pre-shift? Yes, ma'am. I do think that is appropriate to continue doing symptom screening at the beginning of a shift, particularly in a fire station where you have that sort of communal living environment. I think that's very prudent to continue to do that at this point. So I would like to, again, thank Dr. Cho for taking the time to be with us this afternoon. He is incredibly busy, as he has been for the last 7 or 8 months. It's amazing to me that he still has hair. It's shocking, really. I couldn't seem to manage that. So in any case, Dr. Cho is a physician who specializes in infectious disease. He is laughing at me now. That's good. He specializes in infectious disease. He's on the faculty at USF, and his day job is the director of the Florida Department of Health in Pinellas County. So he is responsible for all things COVID for Pinellas County as part of the overall state and local response. And so Dr. Cho, I invited to come talk to us today specifically about therapeutics, updates we've had in terms of the ability to treat COVID, as well as what we can expect to see regarding vaccinations. I think it's pretty clear at this point that EMS and public safety in general are going to have a role in terms of rolling out any vaccination efforts. And so it's probably to our benefit to have an update as to where all that stands and some idea of what we might be asked to help do. So Dr. Cho, thanks again for joining.
Thank you, Dr. Jameson, and thank you for having me. So again, the objective of my talk today is really to go over in 2 parts. Number 1, touch base on therapeutics, but then also give an update on what's been going on with the COVID vaccine to date. And obviously there's a lot of unknowns still out there. I think that's been one of the more challenging things with COVID. Whereas we have had decades of information and studies for things like chronic diseases and heart disease and other infections, we've been really working on the fly with information's really coming out in real time over the last 7 to 8 months. So along that line, given the profound impact of COVID, there has been a race to find effective treatments and vaccines. And while we've made some strides in that regard, there's still a long way to go. So again, let me dive in and start the talk with a little bit of the therapeutics and what's out there, what's available, and what's being studied at this time. And to understand some of the therapeutics and medications used to directly treat COVID, you have to understand a little bit about the pathophysiology. So with COVID, they target nasal and bronchial as well as lungs pneumocytes through viral structure spikes, the S proteins, those things that you've seen the images of the COVID virus with those little spikes. That's that S spike protein. It binds to the ACE2 receptor, which ultimately gains entry into the cell. It multiplies in the infected cell's cytoplasm, and that's the early part of the disease. Concomitantly, the body induces that inflammatory type of response, releasing cytokines and interleukin response, and ultimately resulting in the severe form of the disease, resulting in things that we see in severe cases such as ARDS, acute respiratory distress syndrome, renal failure, among other sort of complications. So think of it that way early on, and even from a therapeutic standpoint, you want to target the viruses. So working with things that are antivirals, the remdesivir, the convalescent plasma, but later in the course, you're trying to work against your own body's inflammatory sort of systems to prevent those more severe complications. So in that context, I'll present some of the medications available later on. The other thing I do want to touch is the definition of severity of this disease. And I think I'm presenting the FDA definitions as when they're creating the therapeutics, what constitutes mild, moderate, or severe. For mild, with COVID, as we all know, has a constellation of different types of symptoms. But what characterizes mild diseases are things like fevers, malaise, cough, upper respiratory symptoms, among other things. But when you start getting shortness of breath and dyspnea is when you sort of bleed into the moderate range. And for severe COVID, the definition by the FDA is less than 94% on oxygen saturation on room air, requiring supplemental oxygen or mechanical ventilation and or ECMO. So with that, I'm going to start off with some of the general considerations before I get into a little deeper dive of the medications that are available and being studied for COVID. So some general considerations, and this is more in the setting of a hospitalized COVID patient. There are a number of sort of recommendations out there, one of which is that if someone has confirmed COVID, that they do not give empiric antibiotics. What they're finding is that bacterial secondary or super infections are not that common and prominent with COVID infections, although if a diagnosis isn't clear, certainly you don't want to delay that treatment of community-acquired pneumonia or other bacterial pneumonias. Now, early in this pandemic, it was thought that once you were infected with COVID, that you did not necessarily, you had a less of a chance of developing a co-infection or having a co-infection, but that was proven incorrect by a number of studies. So keeping that in mind, especially as we're entering into the flu and respiratory symptoms, I think is important because you may have multiple viral infections concomitantly. At the same time, I've also seen instances where people have COVID on their mind as a primary diagnosis when they've missed bacterial pneumonia. So it's important to make sure you have a sort of a broad differential list when dealing with these hospitalized individuals. I'll touch real here briefly, and I think there was a question as it pertains to the flu shot. I think one of the key messaging that I've given with the flu season this coming year is that more important than any other years, it's important to get the flu shot. The reason being is because a number of organizations still institute some sort of symptomatic screen, whether it's self-screenings or that with the aid of a staff. And as you all know, the flu and the COVID symptoms are very similar. And then on top of it, if you have a bad flu season, you're going to be compounding the morbidity and mortality of the flu with the COVID that's going on. Keeping in mind that we are unfortunately this year seeing an increase in all-cause mortality, which COVID is a big player of. Other considerations is DVT prophylaxis. Several studies have suggested there's a high rate of thrombotic events in hospitalized patients. This virus is pretty pro-inflammatory, can induce the coagulation cascade, resulting in things like pulmonary embolus, DVTs, arterial limb issues, limb ischemia, strokes, as well as heart attacks. There isn't a consensus on whether you use full dose treatment or prophylaxis dose, but at minimum, you should use prophylaxis dose for all hospitalized patients with COVID. There are studies that showing the benefit of full dose anticoagulation therapy as well, decreasing the risk of going into respiratory failure with intubation. Let me jump into the medication. So going to start off with the medications that have the strongest evidence in terms of efficacy and effectiveness towards the COVID virus. So I'm going to start with dexamethasone. There really has been the greatest amount of information and showing the benefits against COVID with dexamethasone. What's exciting about it is this is a medication that's been around, so relatively low cost, readily available. It's, and the World Health Organization now listed as essential medications for COVID. So keep that in mind. What got me excited is that in the New England Journal of Medicine, a randomized control study involving over 6,000 individuals that were placed in either those receiving dexamethasone, those receiving placebo. It clearly showed a 28-day mortality benefit for those that are on dexamethasone. Relative reduction in mortality appeared to be greater among patients on invasive mechanical ventilation compared to those that are on non-invasive oxygen therapy. So going back to what I said earlier as it pertains to the pathophysiology, again, you're tackling more that severe form of the disease. What that study showed is a reduction in mortality of about a third on those on mechanical ventilation and ECMO, and a 1/5 reduction of mortality for those on non-invasive oxygen therapy. And along that same line with the pathophysiology, mortality benefits were not seen among patients who did not require respiratory support. So if dexamethasone isn't available, other glucocorticoids with equivalent doses are reasonable alternatives. There has, again, just because there isn't a great amount in volume of studies out there, there isn't a set guidance or recommendations, but I do follow the Infectious Disease Society of America, just given my background, and they've put out a few recommendations on various medications. For dexamethasone specifically, the Infectious Disease Society of America, or IDSA, recommends among hospital patients with severe COVID to use glucocorticoids. Among hospital patients without hypoxemia requiring supplemental oxygen, the panel suggests against the use of glucocorticoids just because of what that study did show. Obviously, with anything steroids, it can be immunosuppressive, so using caution in the setting of an infection and other infections is important there. Moving on to remdesivir, this is a novel antiviral for COVID. It works against the viral replication. It was FDA approved under emergency use authorization, EUA, for hospitalized adults and children, regardless of severity. And there's been a number of studies involving this one as well. The largest being a multinational trial of greater than 1,000 patients with confirmed COVID and pulmonary involvement. What it showed in that study is a faster recovery time, 11 days for those that are on the remdesivir compared to the 15 days that are on placebo. So it does show a benefit in terms of recovery time. However, there was no statistically significant mortality benefit, and it shouldn't come out as too much of a surprise. Other antivirals for especially respiratory viruses, like for example, Tamiflu against the influenza, it has never shown a mortality benefit. So it really goes along that line. And what Tamiflu does, similar to what remdesivir showed in this particular study, is that it decreases, it increases the recovery time. There are other studies out of China failed to show similar benefits, but there was a lot of variables with that. And if what they're recommending, and going back to the Infectious Disease Society of America recommendations for hospitalized patients with severe COVID-19, they suggest the usage of remdesivir over no antiviral treatment. If supplies are limited, they would prioritize those requiring supplemental oxygen rather than the more higher flow mechanical ventilation or ECMO. And some of the common side effects for remdesivir includes nausea, vomiting, elevated liver function tests, acute renal failure, fevers, and hyperglycemia. So I'm going to stop there with the remdesivir and dexamethasone. That does have, again, the best data and studies that really supports the effectiveness against COVID. And from there, unfortunately, the evidence is inconsistent and really doesn't show that kind of similar types of benefit, but I will touch on them as they are in the news. It's in the medical literature. So starting off with a convalescent plasma. And I think you're probably all aware of the background of what convalescent plasma is. It's recovering the plasma for those that have recovered from COVID infections, and then giving that plasma to someone that is infected with COVID to provide that passive immunity. However, unfortunately, just given the studies that are out there and have been sort of inconsistent, the role is uncertain at this time, which is disappointing to me, actually. As other diseases, other emerging infections, such as Ebola a few years ago, the convalescent plasma did show some benefit there. But two randomized control studies and several observational studies really has been inconsistent in terms of the benefit. So I won't get into the details there, but it's been inconsistent. But despite that, in August of 2020, the FDA granted an EUA for convalescent plasma for patients hospitalized with COVID-19, and going back to the IDSA recommendations among hospitalized patients, just given the weaker evidence out there, they only recommend its usage in the context of a clinical trial. Moving on to tocilizumab, I'll call it TOSI for short. It's a monoclonal antibody. It works directly against interleukin-6, again, part of that inflammatory cascade. There was a Lancet study that came out in August, which was retrospective, that did show possible reduction in mortality. However, the randomized control studies did not show similar benefits. So again, it's sort of inconclusive with the efficacy of this particular medication as well. And just given sort of the inconsistencies, again, with this particular medications, the IDSA recommends among hospital patients only to use in the context of a clinical trial. And it gets tricky, especially with any monoclonal antibodies that are out there. The monoclonal antibodies been used for over a decade on various rheumatologic diseases, lupus. We all know that it can suppress the immune system with a potential side effect of causing superinfection. So just weighing the risk benefits, it's just not there, unfortunately, with tocilizumab at this time. Moving on to hydroxychloroquine. I know that's been on the news a lot, and I know the president has also mentioned it as well. Hydroxychloroquine is an anti-malarial, anti-inflammatory used for autoimmune diseases as well as rheumatoid arthritis. In a laboratory setting, in vitro, both hydroxychloroquine and chloroquine may inhibit the SARS-CoV-2. And early in the pandemic, there was a release of a study, a small French study, that hydroxychloroquine in conjunction with azithromycin did show a potential benefit. However, it was unable to be reproduced by other randomized and larger control studies. Also, there was a number of studies out there, including pre-exposure prophylaxis as well as post-exposure prophylaxis, with none of the randomized control studies showing really any benefit. However, there was a retrospective study from Michigan with over 2,500 patients that did suggest a decrease in mortality. However, there was the biggest confounding variable with that particular study is in the hydroxychloroquine arm, there was a disproportionate number receiving dexamethasone. And as I mentioned, there has been studies that have shown to decrease mortality with dexamethasone. So there was that confounding variable. In terms of adverse effects, the biggest thing that we all worry about with hydroxychloroquine, because it is used in conjunction with azithromycin, is that QT prolongation, which obviously can lead to torsades de pointe and ventricular arrhythmia. And given the lack of data, and in fact some evidence and some even smaller studies showing an increase in mortality due to the side effects, the FDA in June revoked its EUA, noting that the unknown and potential benefits no longer outweigh the known and potential risks. So it is no longer recommended by the FDA. And similarly, the IDSA recommends against hydroxychloroquine with or without azithromycin, just given the studies. Let me touch real briefly on Pepcid, famotidine. You guys probably have seen it in the news as well. It's unfortunately, the fact that it's been in the news is that it's caused some shortage of the H2 blockers for those that need it, and it's generally treated for GERD, gastritis, ulcer disease. So there has been some retrospective studies that did show the benefit, but again, the data is still lacking for the most part in terms of the benefit. And along that line, the IDSA does recommend it does not recommend famotidine to use for the sole purpose of treating COVID outside the context of the clinical trial. So I think there are a number of studies out there with Pepcid, with other H2 blockers, and the data, unfortunately, is not out at this time. And just wrapping up the therapeutics piece of this, there is a number of medications really under study at this time. They're looking at older medications, older HIV medications, most notably pinavir, ritonavir, which is Kaletra. But again, the data is not there yet. They're looking at antiparasitics with in vitro activity against COVID, such as ivermectin. There's been small studies that does potentially suggest some benefit. But there is a whole slew of therapeutics out there. They're looking at immunomodulators, hyperimmunoglobulins, interferons, other antivirals. But again, I do, before I leave the therapeutic section, just keep in mind the two with the strongest evidence, as I mentioned, is dexamethasone and remdesivir. So when we do have these hospital calls and when we're working with our hospital partners, I think it's key that at least for those two medications, we ensure that they do have supply. Ample supply of those medications.
Can we pause there for a couple questions? Would that be all right? Great. That was a ton of knowledge. Thank you. So we got a couple questions here to go into, and then I want to see if I can distill down the stuff that you just said for a simple ER doctor like me. And so first of all, remdesivir, it sounds like the bottom line is faster recovery time, no definite mortality benefit. Did I get that right?
Yes, and it's better probably with the lower end spectrum of the severe COVID disease. So those on nasal cannula as opposed to mechanical vent or ECMO. Okay.
And then the steroids, dexamethasone, is a good survival benefit or just faster improvement?
No, it's really in a randomized control study. It's really been the only medication to show a decrease in mortality, a 28-day mortality.
And that's specific though to folks who are requiring ventilatory support, correct?
Yes.
So that'd be the sicker patients do have a mortality benefit from the dexamethasone. So we have a question from the audience on that.
Sure.
And that is, we don't have dexamethasone on the truck. We have solumedrol. We don't know that solumedrol would have the exact same activity, but we would expect it to have a similar. They're used relatively interchangeably for treatment for lots of things. The question is it conceivable or would it be beneficial to try to get dexamethasone into our pre-hospital bundle of care for suspected COVID patients so that we could get it in as soon as possible?
That is a good question. I don't, so I think what you're referring to is your thought processes of, actually, you can refresh my memory though. For COPD and asthma, do you routinely give the steroids on the field?
We do. So we give solumedrol for just about any asthmatic or COPDer who's bad enough to call 911. Just like most of them will get their solumedrol in the ER if they haven't already gotten it, and then often get sent home on a prednisone taper or something like that. So we had initially pulled back from our solumedrol for suspected COVID patients based on some of that early data. Right. And there was a discussion as to whether we should put it back into protocol after we started to see these studies about steroids being beneficial. And I elected to hold it for the moment and not push it back in for those folks, because it seemed like it was the more severe people that were requiring ventilatory support. And because the mechanism of action of steroids is such that a 20-minute or 30-minute delay in administering the steroids is likely not going to be that impactful, given the fact that they have to go all the way to the cell and do that kind of stuff.
Right. So
are you aware of anybody using steroids, specifically advocating dexamethasone being pushed as early as possible in the course, or only after consultation with the specialists?
And I was going to sort of touch on that. I'm not aware of the studies in terms of the timing. If there's a timing benefit to give it as soon as possible versus waiting until there's assessment. My only fear is that if someone presents with respiratory distress and on the field you discover it's more in another, it's an infectious etiology, but you can't confirm whether it's COVID versus pneumonia or bacterial pneumonia coming acquired, is there going to be a benefit? So there is some questions there. Something I can look into a little further, and just to let the group know, I believe the equivalent dose for Solu-Medrol, the studies show that dexamethasone is relatively low dose, 6 milligrams IVPO for 10 days. So what that equates to is Solu-Medrol 32 milligrams, if I did the calculation correctly, that steroid equivalent calculation.
Yeah. Okay. So there's a bunch of other questions about testing and herd immunity and influenza and all that stuff, but let's maybe keep pushing through the COVID vaccine stuff, or whatever other awesome bits you have for us today.
Okay.
Before we get into that stuff.
I'll touch base now on the COVID vaccine. I'll be willing to touch base, talk and answer questions as it pertains to the therapeutics and vaccines, or other questions that the audience may have. But let's start with the COVID vaccine and some of the information that's out there currently. Starting with a little bit of the background, there has been a number of vaccine candidates that are being evaluated for the prevention of COVID. And it's been sort of an exciting field. They're looking at new delivery mechanisms that haven't previously been used in other vaccines or widely used. Things like messenger RNA is I think they may have used it for another, I think Ebola, but no, really, it's not widely used in other vaccines. They've used other things like viral vectors, transporting an innocuous virus into the body to expose the immune system to an antigen. They're looking at and using and studying nanoparticles at this time, as well as the common, more established delivery vaccines, such as inactivated and recombinant vaccines. There is a number of vaccines out there. I know there's several COVID trackers out. What I use is the New York Times COVID tracker, and what they look at is internationally. And as of the last week, there was 27 in phase 1. That's earlier phase of the vaccine studies. Phase 2, there's 14, and phase 3, there's 11. However, the 4 we're tracking in phase 3, the 4 U.S. involved or backed vaccines, there's 4 of them in phase 3 at this time. The development of these U.S. backed vaccines has been in collaboration with Operation Warp Speed from the HHS, as well as the DoD. The FDA does state in their target goal in their basement for effectiveness is 50%. They've made that statement. 50% of vaccinated people be considered effective. And just to give you a context of other vaccines, MMR vaccine for measles is probably one of the most effective vaccines out there. It's 97% effective for measles. Tdap is about 70%. And annual vaccine varies from year to year, but ranges usually around 50 to 60%. Let me touch base on the vaccine studies, because it's something that we deal with in the public health side, but really with the vaccine and how rapid it's developing, it's sort of been in the forefront of the various phases of vaccine development. It starts with a preclinical phase, which is testing on cells and giving it to animals, looking at both viral, the antibody titers, as well as the effectiveness for that particular animal. Then it moves to the human trials through phase 1. This is generally a very small number. What they look at is various dosing regimens, and they try to parse out the best dose that would exhibit the neutralizing level that is theorized to provide protection. And phase 2 is that they increase the sample size by hundreds of people. What they're trying to do in that phase is seeing if they generate a consistent immune response, looking at neutralizing antibody titers. And then lastly is phase 3, which is really the most important phase to me. So if the proof is in the pudding is actually phase 3, because what they do is they involve tens of thousands of individuals. They separate them into those receiving vaccines and those receiving placebo. And what you're going to do at the end of all of this is compare the rate of infection of COVID between those two arms. It's because a number of vaccines out there, the neutralizing titers does not necessarily correspond to the effectiveness of that particular vaccine. So again, this is the key, I think, here of phase 3, and it underscores the importance of not rushing through this particular phase. You may have also heard of a limited approval. This has not occurred in the United States, but they are using it in China and Russia. What they did, unfortunately, is that they did forego their phase 3 trials. It's something that the US scientists don't recommend, but it is something we'll watch from an academic and scientific level, just as to some of the outcomes. Unfortunately, they're doing essentially phase 3 in real time. Public perception, I think, is important to sort of talk about as well, because you can build a vaccine, you can develop it, but if people aren't willing to get that vaccine, you're not really doing any good. And I can, for the most part, understand some of the concerns out there. This has probably been one of the fastest vaccine I've seen developed. And just to give you some context, the human papillomavirus, or any vaccine for that matter, it took over or close to or over 10 years to develop from the preclinical phase to mass production. So this is going in essentially warp speed in terms of development. There was a Pew Research study that was a survey that was conducted about a week or two ago that showed that fewer Americans now are saying that they would take the COVID vaccine compared to 4 months ago. So in May of 2020 of this year, when they conducted that survey, 72% were willing to receive the vaccine. That number in early September dropped, unfortunately, to 51%. So I think there's going to have to be a messaging component to this once the vaccine is ready and rolled out. What's reassuring to me, however, is that there's never been this much money that's really aided in the development of vaccines. There's been a multinational collaboration between countries, between various pharmaceutical companies. So the motivation is out there to really develop the vaccine. They are providing the resources to do so. The other assurance for me is that a lot of independent expert panels will be reviewing the data separately. We also have the Advisory Committee on Infection Practices, ACIP, that will be reviewing the data, making the recommendation based mainly on the phase 3 data. And unfortunately, those are still ongoing, and I have not seen any preliminary publications of the phase 3 data out there. So what I plan to do is look at what the experts' interpretation of that data is. Once it does come out, I'll be looking at the studies, especially most notably on the phase 3, and if it really cuts the mustard, I'll be even getting the vaccine myself. So I am going to touch base briefly on the 4 vaccines that are in phase 3 in the U.S. That's supported by the U.S. Starting with the company Moderna. What they have is a lipid nanoparticle containing mRNA vaccine that is for the SARS-CoV spike protein. It is a 2-dose vaccine separated by 28 days apart. Storage is negative 4 degrees Celsius. I mentioned that it's important, especially for the next vaccine I'm going to mention, is that the mRNA vaccines are pretty fragile, it's pretty brittle, it degrades rapidly. There has to be a stability component to it, and it does require that cold temperatures. So when you think about the logistics and the distribution, that does come into play there. The clinical studies for Moderna does show that vaccinated monkeys quickly did clear the virus. So that is at least in monkeys showing that efficacy that we're hoping for. We see similarly in the phase 3 human studies. They did publish the phase 1 studies in the New England Journal. It does show that it does generate both the antibody and what we call the cell-mediated immunity, the T cells, capable of protection in animal models. Some of the adverse effects of that was published shows most common being the mild to moderate pain at injection sites, similar to any other vaccines. They also saw fatigue, chills, headaches, and myalgias. They didn't, and again, keep in mind this is a 2-dose vaccine. They didn't see any fevers with the first dose. However, they did see it with the second dose. And that's important to note because there are some viruses, those that are inflammatory, that once you're exposed to the virus the second time, or an antigen the second time, you could generate more of an immunologic response. And I think that's important. Hate to throw this in here and there, but there was an RSV, a respiratory syncytial virus vaccine that was studied and tried to roll out in the 1970s. And what they showed is once they got the vaccine and a person was exposed to RSV, what it did was it generated a cytokine storm, and it had a huge inflammatory type of response in reaction to those that did receive the vaccine. And that vaccine unfortunately did fail. And I hope we don't see it there, but the phase 3 studies and the safety elements of all these phases are going to tell us that piece of it. The durability.
Can I interrupt you for 1 second there? So
yes, sir.
people talk a lot about safety and is a vaccine safe or not? So that's one example of how a vaccine might not be safe. Is there, like, what other things might make a vaccine unsafe? Not that it doesn't work, but actually unsafe.
Well, I think what they're also beyond that kind of inflammatory response and the prevalence compared to, again, you're comparing phase 3, the placebo versus those that receive the vaccine. So you'll have that comparator, but you're looking for that kind of inflammatory response. You're going to look for unusual types of infections. You're looking at rare types of reactions like, and I'll touch on this with the AstraZeneca, with the neurologic symptoms such as transverse myelitis, anything rare in terms of safety protocol. Safety sort of practices and safety outcomes there. Some of the safeguards that they are working on, I'm not sure if everyone's aware, but for standard vaccines, there is a self-reporting system. It's called Vaccine Adverse Events Reporting System, VARS. That's been around. What they plan to do with any of the COVID vaccines that are sort of rolled out is to develop more of an enhanced version of the VARS. I think they're going to be calling it V-Safe, so you can track the outcomes better in that system. They're looking for adverse events, but I think with just the attention to this particular vaccine, I think the safety piece is going to be key. And just once they publish everything from all the phases, because what the companies have done is sporadically release that information. I think it's an opportunity to sort of look at some of the safety profiles and the adverse events out there. Hopefully that answered your question, Dr. Jameson.
Yeah, thank you.
Okay, so that is the Moderna vaccine. Moving on to the Pfizer vaccine. So it's something to keep an eye on this one. The reason I say this is out of any of the pharmaceuticals with these vaccines, they've been the most aggressive, announcing that they may have preliminary data as early as in October. So this may be actually one of the first ones out of the gate. So something to make note. This particular vaccine is in conjunction with biotech. I think it's a European pharmaceutical company, and Fosun, which is a Chinese company. But this, similar to the Moderna vaccine, is another mRNA vaccine. It encodes for the receptor binding domain of the spike protein. Again, that seems to be the target with a lot of vaccines, those spike proteins on the COVID virus. This, again, is a 2-dose vaccine separated by 21 days. These phase 1, and they've combined some of the phases. The phase 1-2 studies did show that it does generate the neutralizing antibodies. The most common adverse effects were headaches and fatigue. And again, adverse events, as I sort of alluded to with the Moderna, it was higher with the second dose. So something that I think we need to be mindful of. This one is going to be, of course, this is the one that's going to be the first out of the gate, because this is the one that, in my mind, that's going to be the logistically the toughest one. This is the one that requires the ultra cold freezer at -70 or 80 degrees Celsius. That's colder than the Arctic Circle. So making sure that if this is the one that crosses the finish line, that we have the capabilities to store something like that. I don't think the specs are there. Something that we do need to know and have a better understanding of is, once you thaw it, how soon can you use it? The other limitation with any of these vaccines is a majority of them that are in the later phases are in multi-dose vials. That once you start vaccinating somebody and open up that vial, that whether it's 10 or whether it's 100 in that particular vial, you need to line them up. So that closed pod sort of setting is important, so that you don't waste any of that vaccine. Moving on to the AstraZeneca Oxford vaccine. This is the viral vector, an adenovirus vectored vaccine that does express, again, the spike protein from the SARS-CoV. It is a 2-dose vaccine, 28 days apart. The phase 1-2 studies did show some safety and did elicit strong antibody response, but keep in mind those early studies are a small sample size. This of note did make the news because they did have to halt the study because of some neurologic side effects, most notably transverse myelitis. I didn't get a chance to review the outcome of that, or I'm not sure if it was published in a journal, but they did resume 3 days later. So something to keep an eye on in terms of the neurologic, whether they, my understanding is they did not attribute it to the particular vaccine, that this person may have had underlying multiple sclerosis, which does present like transverse myelitis. But
Can I make a comment there?
Yes, sir.
So one, can you tell us what transverse myelitis is?
Okay, fair enough. So both MS and transverse myelitis is a demyelinating. This is like the insulation part of your neural tissue. So what it does is that you can have focal sort of symptoms. Transverse myelitis is more in the spinal cord, so you can have weaknesses and paresthesias as such. And MS it can involve the brain. So that's both of which are, again, demyelinating diseases.
So to boil that down, it's a degeneration of the insulation on the spinal cord, which can cause, in particular for transverse myelitis, can cause something that looks like a partial spinal cord injury, where you're knocking out a couple of those motor tracts or sensory tracts. And so the patient might have like a unilateral paralysis or something of that nature that we would see. So it's pretty rare. It does happen sometimes in sort of post-viral like patients. And so that's comment number one. Comment number two is that that pause in enrollment and pause of the study that made the news, my take is that that was a standard part of what happens in a phase 3 trial, and there wasn't anything particularly special about the fact that they paused the enrollment. And that's exactly what's supposed to happen when they have an adverse event and need to take a second to see whether or not they think they're attributing it to the study intervention. Did you get any other kind of sense that that wasn't sort of standard operating procedure when something like that occurs?
No, I completely agree with that, James. And it is standard operating procedure. It's done with every other vaccine. And I think, usually the public doesn't watch every other vaccine development, but this is common practice done with every other vaccine truly out there. And if anything, it should, to your point, add some reassurance that they are pausing and doing the research and making sure there isn't that correlation that the vaccine is causing these types of symptoms. So it is normal processes.
Yeah, I don't think that was reported that way on the news. It was like, oh, there's a problem. But I agree with you. To me, that was actually reassuring to see them following standard research and development processes and not taking shortcuts just because of warp speed or whatever.
Agreed. Okay, let me move on to the last vaccine there, the Johnson & Johnson in partnership with Janssen. This is another adenovirus vaccine, again, encoding that spike protein. The advantage this one may potentially have is that it's a single dose rather, as I mentioned, the other three that I presented here is a 2-dose vaccine. However, there isn't a lot of publication, unfortunately, with this particular vaccine out there. So in terms of the efficacy, I don't have that as available as the other vaccines. It did just of note launch into phase 3, so I'm sure more information will be forthcoming regarding that. So I'll stop there in terms of the 4 vaccines that I'm sort of tracking at this time. You've probably seen sort of the press conferences that the CDC's held, Fauci's held. They are optimistic that at least one of these 4 may be approved by sometime this year, with even potential for some limited availability at the end of this year, probably more so early next year, and more of the availability to the greater public sometime in the spring or the summer of next year, I think is the rough timeline. But again, it's hard to say without seeing those types of phase 3 studies. And then lastly, I will touch on a vaccine distribution plan. I did hear a comment in one of our planning groups. It's like flying a plane while trying to build it. It's because we don't have which of these vaccines that are going to cross that finish line. And it's going to be difficult. There's going to be some logistical challenge. I suspect it's going to be a little bit harder. We've done mass vaccination before, most notably with the H1N1. But just given some of these other factors, the multi-dose, the need for some the freezers, I think it's going to present some of a little bit more challenge. The CDC did release a playbook. They divided into 3 phases: a limited availability, which they'll prioritize healthcare workers, first responders, and other essential workers. And then number 2 is sufficient, where they have sufficient supplies for the general population. And number 3 is surplus, which I don't think is going to be a problem, at least in the foreseeable future, is having excess vaccines. They're focusing on the hospitals as the possible first recipient, especially given the freezer component of this. And I am aware that there is a survey that is going out or has gone out to the hospitals to both assess their interests and capabilities. And as I sort of mentioned, the logistical challenge with the refrigerations, the dose, the multi-dose aspect of it. Some of these vaccines do require mixing kits, so those have to be all factored in with some of the planning piece of this. And in terms of this, there's been a number of state working groups sort of working behind the scenes on this, from the Department of Health. There's a hospital working group. There's ACA is working on the potential vaccination for long-term care facilities. And I don't know if you wanted to speak on this, Dr. Jameson, but the EMS working group looking at either staffing augmentation, possible self-administration of the COVID vaccine among the first responders, including law enforcement. And I think you relate to me that they're going to be also sending out a survey in the near future as well.
Yeah, I heard from Dr. Shepke, the state EMS medical director, that EMS agencies are going to get a similar survey to the one of the hospitals, trying to figure out the best way to do it. But it does seem clear from my discussions with him that the state is anticipating that first responders, specifically EMS and fire, would likely be expected to help vaccinate themselves in support of the health department or the state, and could also be called upon to assist as a force multiplier for dealing with other vulnerable populations like the long-term care facilities, in much the same way that we assisted when it came to PPE and infection control processes there. So I think that is pretty clear. And it's actually one of the reasons why I wanted you to come on today, was because I think that there's a reasonable possibility that within just the next few months, we're going to receive a shipment of vaccines from the state and be asked to go ahead and get ourselves vaccinated. And so that's going to need some thoughtful consideration on everybody's parts to make sure that they're comfortable not only administering, but themselves personally accepting a vaccine. And so I wanted to start the conversation today about these vaccines and where we are and what the processes are, partly because I do think that that's something we're going to face directly in the pretty near future.
So let me end with just my public health message. You get your flu shot. I think that's important this year. But beyond the flu shot, they don't know the spacing or the timing of that spacing, but they are recommending that you cannot get the flu shot and the COVID shot vaccine concomitantly. So what we've been pushing for, especially for those that are first in line to get the COVID vaccine, is that to get your flu shots early this year. So I did just see a report from the Kaiser Family Foundation that does show Florida is third from the bottom in terms of our flu vaccination rates, unfortunately. So a huge opportunity and gaps there. We're at 37.62% according to their report. So I think it's important to push the flu shot and then look at what's going on, look at the studies as it pertains to COVID vaccine. So with that, I'll stop there. I want to thank everyone for their attention and I'll take any questions.
Awesome. Thank you very much. So for those of us who are procrastinators, this is not the year to procrastinate on your flu vaccine. I almost got one the other day, but there was too long a line at Publix for the $10 gift card, which I think they're still doing. We do have a couple of questions here, and I'll ask folks to start popping more questions into the chat so we can take advantage of as much time as Dr. Cho will give us. The first question was on the COVID-19 and influenza, and I think you sort of already touched base on that, but I think what I think this is Jeremy is getting at is what would a influenza outbreak this year that's near normal or worse than normal do to our efforts fighting COVID? People have started to refer to this as a twindemic if we get a bunch of flu cases. And I think they're alluding to the fact that you might not be able to clinically distinguish those two things. And so it might require us to do a lot more of extra work in caring for what would normally be not a particularly onerous patient. Is that where you think they're going with that?
I think so too. Again, I think I've mentioned this before in various presentations, but we cannot have a severe flu season. It just will compound everything. As I mentioned, we've already seen an increase in all-cause mortality. That'll just add to it, and the burden on the healthcare system is going to be huge. What's reassuring is that there was an MMWR report that showed the flu rates in the Southern Hemisphere. They just passed their winter and passed their peaks of their flu season. And due to the same practices we do to prevent COVID, such as social distancing and masks, it actually had the historically low flu rates down there. And I'm hoping to see something similar here in the US and in Florida.
Great. Couple of other ones. Here's one. With phase 3 flu season and the recent, at least early or small upward tick in the cases, at what point or threshold would you begin to worry about situations like New York? And I'll ask Jeremy to clarify that a little bit. Are you talking specifically about the communities that are seeing significant increase in cases in Brooklyn, or are you talking about, I'm not sure exactly what you're talking about. So maybe if you can clarify that, Jeremy. But one of my concerns is as we get to phase 3, as we see restrictions loosening, that if we then see a subsequent significant increase in cases, it will be all the more difficult to reimpose or redeploy those types of restrictions. Is that a concern you share?
No, absolutely. And what scared me, if you guys have a moment, to take a look at the disease trends over in Europe, they clearly showed that second wave, and it's something that we hope we don't see here in Florida or the United States. But if you look at the UK, Spain, France's second peak is actually higher than what their first peak was, for example. So certainly that could be it could be potentially bad for our healthcare system. The thing, and Dr. Jameson, you alluded to it, is you're absolutely right. What are some of the triggers? Because we have to nip it in the bud early in any increases, because everything else does have that lag. So what are some of the triggers? We've have had discussions on a regional level with the healthcare systems as to what, rather than looking at when we can take things away, when should we ramp up? Because as you've seen in terms of our testing capabilities, we've pulled back a little bit. The demand hasn't been there, or we've sort of backed away from our surge planning. But what are the triggers that does tell us to ramp those services back up? And I think we're going to try to work on that on a regional level.
Cool. So here's a slightly more clinical question, which is any studies or even personal experiences of patients developing spontaneous pneumothoraces after being diagnosed with COVID-19, specifically like a month or 2 months out from it?
I believe, if I'm not mistaken, from the studies that the pneumothorax is in conjunction with the ARDS, because you see it with ARDS all the time, or severe respiratory involvement or pulmonary involvement of the COVID vaccines. I'm not too aware of a spontaneous pneumothorax in the setting of a clear lung. However, it may occur. We're actually learning a lot more in terms of the lingering effects of COVID. There's been a series of studies out there. I thought I read an article that's called some of the people with persistent symptoms as the long haulers. That people have reported months after they were supposed disease-free, usually 10 days, that they still had respiratory symptoms. You've probably also seen that report where they did test on athletes where 15% of individuals may have had myocarditis, which was inflammation around the heart muscles. That may have long-term consequences and lead to even arrhythmias if it does result in scarring of some of those heart tissues. So in terms of the long-term implications of the disease, I think that's an unknown, and it does scare me, frankly, because we don't know what we're dealing with. And there has been some statements that this is innocuous, but it's too early to even say that at this point, just because of potential long-term complications.
Yeah, I would agree. I think the more we're hearing about those folks that are having persistent symptoms or permanent structural damage to the organs that were involved, the scarier it becomes. And I said at the beginning of this thing, I didn't want to get it up front because I wanted us to learn more about it. And I'll say now, I still don't want to get it because even though my risk of dying in the hospital might be less because we're better at treating it with all those drugs you talked about, I still don't want to get it because, I know doctors who went from, marathon runners to not doing too well, a resting heart rate in the 50s to a resting heart rate in the 80s and a resting blood pressure of, 110/70 to a resting blood pressure of 140/90. And there's no sign that that's going to recover necessarily. So I do think it's still a bit of a roll of the dice about what the long-term effects of this will be. And that's not without precedent, right? I mean, other epidemics or pandemics have had similar waves of subsequent long-term morbidity associated with them. People talk about that all the time with the neurologic stuff after the 1918 flu. So I haven't heard specifically spontaneous pneumo though, Chief Cepetto.
It's still so early. I think we're going to continue to learn more and more about this.
Oh, for sure.
Jeremy responded and said, yes, he was talking about the Brooklyn example.
Yeah, so I think the big concern is when things open up, how do you know when it's time to try to ramp that back down, and that's extremely difficult. I don't know if anybody has the good answer to that right now. Another one is related to antibodies. So you might know, Dr. Cho, that we're currently doing IgG antibody testing, offering to all first responders. And that's a good thing to bring up because there's a couple of clarifications I wanted to put out there on that. So I've heard some interesting theories floated from folks about why we're doing that or to what end. So first of all, it is simply a benefit that the county EMS system is offering to all first responders in the system. If you choose to use that and get that answer, great. If you choose not to, no problem, that's on you. I would encourage everybody, because it's probably a useful piece of information for you in your own personal risk mitigation, risk calculations. But to be clear, there is no planned research on this. If something interesting comes out of the data, we might share it, but I've heard people saying that we've got big research studies planned on this or something like that. That's not true. This is a straight up service offering to the frontline clinicians. And we're thankful that the county decided to fund that for you all. And it really has nothing beyond that in it. It's for your own information and for the unified command and all of us to figure out if the steps we're taking are being effective and how much our workforce is being impacted by this. But there's nothing planned beyond that. And so as that Chief Cepetto asks, is it possible for somebody to not have IgG antibodies 60 to 90 days post COVID-19 positivity test? So yeah, I think there's been studies that pretty clearly show that in some people, the antibody response may wane and not be measurably positive after a period of maybe 90 days or so. Maybe 4 months might be a little closer. But I think it's worth emphasizing that that does not necessarily mean you are not immune. The antibodies are just one piece of the immune system response. But Dr. Cho is the infectious disease specialist. Mm-hmm. So what do you think about that, Dr. Cho? Would you
more into the immunology piece of it? But
yeah.
No, I'm kidding. So it is possible. So let's talk about the formation of antibodies. What they found is it really is dependent on how severe of a COVID case you actually had. So those that have had more of a severe case of COVID, they found a higher rate of developing those kind of antibodies, whereas those that had more of a milder case, quote unquote asymptomatic cases, they've seen lower chances of both the vaccine, antibody formation, as well as the sustainability of that antibodies. What's concerning to me in terms of the longevity early on is there was studies that showed that the antibodies only stayed about 3 months. However, I think there was another study that just came out that showed that it looks like it's mainly more 4 months. But to Dr. Jameson's point, that's only part of the stories with the immunity. There was a article on theories right now is that there may be more protection than people realize, or even what the seroprevalence studies show is that you can store the antibody information in the plasma in your bone marrow, these plasmablasts. So you actually, once you've seen the antigen, your antibodies can actually proliferate once you're re-exposed to COVID. Additionally, there is that innate immune system, or the cell-mediated immune system with the T cells that does hopefully mitigate some of the aspects of it. There's been some talk about cross reactivity with that kind of defense system with the common coronaviruses, but other studies are not showing that there is that cross reaction. There is, however, a cross reaction with the original SARS-CoV-1, that for those that were infected may have that cell-mediated and other immunity that does provide protection for SARS-CoV-2. But as for the common coronavirus, less so.
Great. Here's one, and I don't know if you can take a stab at this or not. It's really more of a predictive kind of a question. Is from Chief Andoga. He says, do you think that the new Abbott nasal quick test that was just rolled out will be available at some point to utilize by our first responders to screen their personnel prior to a shift?
They're referring to the Abbott Binax?
Yeah, the new one that was just announced last night.
So the Abbott Binax, so that's an antigen test. It's a quick test. It's a 15-minute turnaround. Doesn't require a machine. It's a card. So there's certainly advantages. It appears that the focus in Florida right now, with some of the supplies that we got with the federal government, is again geared primarily for the long-term care facilities first. There wasn't a mention of the availability for the general population or first responders at this time. The other thing I'll mention with that particular test is you have to understand the limitations of an antigen test, which is different than that PCR test, is that they have a high specificity, meaning that if it's positive, it's likely that it's going to be positive. But if it's negative, there could be some false negatives. I think the sensitivity for that particular test was about 85%. So you could be missing actual positive that does test negative. And generally with any of the antigen tests, so whether it's the Binax, whether it's the Sofia Quidel, whether it's the BD Veritor, any negative test, what we recommend is to do a confirmation PCR test for that negative.
Yeah. So I know the governor was in town today making an announcement potentially related to that. I haven't seen what he actually announced yet, but I do think we'll see that test rolling out in a fairly substantial way, and that'll mean we'll have to have a real conversation about what you can do with an antigen test versus what you can do with a PCR test versus what you can do with an antibody test. And we've had some of those conversations, but we'll have to continue that discussion. Make sure everybody understands what we're looking at with these tests. Next question is, do you think there's a possibility, and I'll sort of rephrase this to something that you might be able to give an opinion on. Do you think there's a possibility that if we get vaccinated as first responders, that we would no longer need to wear our full PPE? That's, I think, what the question boils down to.
That's a good question. Number one, it's too early to say. And number two, I think it may be based on the efficacy, the effectiveness of that vaccine. If let's say in the worst case scenario, the vaccine that's approved and processed is only 50% effective, you have a 1 in 2 chance of it not being effective, right? So if that's the case, based on the effectiveness, I would continue to recommend wearing that. Everyone asks about a time frame, right? Let's say in a scenario where let's say a majority of Americans do decide to get the COVID vaccine. I think the CDC just came out and said that it's going to take about 6 to 9 months to do that. You want to make sure that from a vaccination standpoint, that there is herd immunity out there, and the time frame to get to that point is to be determined. And in fact, the percentage is to be determined as well, just given what we're learning about the immune response to COVID.
So can you elaborate on herd immunity a little bit? It's a concept people hear a lot in the news. And, I certainly remember hearing and learning about it in public health school. But what do you think it means to get herd immunity? How many people have to be immune? How does that work?
So herd immunity. So what herd immunity is a protection. This is a sort of a population health sort of context where enough people are exposed or have been infected and have protection against it, so that it protects those that are vulnerable, that those that can't get the vaccine, those that haven't been exposed to the infection. Now, based on the disease, that percentage trigger, whether it's through natural infection, whether it's through vaccination efforts, it can be variable. The estimation right now, and the last thing I think I saw for COVID, is that either through natural infection or through vaccination efforts, that percentage for COVID is about 50 to 70%. For those that are even more, for other diseases like measles that are even more highly infectious, more transmissible, that is probably, it has to be over 90%, for example. So again, for COVID, I think that trigger point to get that herd immunity is variable, and it's not known at this time. Now, what you're also alluding to is natural herd immunity, right? Similar to what Sweden did, is probably what you've heard a lot. Let the natural immunity herd immunity sort of take its course. However, you have to keep in mind that comes with huge consequences, of which is going to be the severe outcomes, including hospitalizations and death. To get to that natural herd immunity, the safer route, as most experts, is going to be the vaccine route, because it is more of a controlled aspect of it. Right now, they are not recommending the similar letting the disease in itself develop that herd immunity through natural infection, similar to what Sweden did.
Yeah, that's I think a good way of describing it. I think I remember an analogy in public health school where the idea was if enough of the people that any case came into contact with were immune, it could slow the transmission rate to the point where the virus couldn't continue to stay alive in the population. So you have a certain number of people in the population that can't get vaccinated, and so the only way to protect them is to make sure that anybody who does get the infection doesn't ever really come into contact with somebody who's not immune, so the infection doesn't go anywhere. And so the idea is if a high enough percentage of the people are immune, that when somebody gets it and is shedding virus, nobody who's not immune gets exposed to that virus, because most people are immune. And so as soon as you get to sort of a threshold tipping point, what people talk about, the R naught, starts to go down, because the number of people that you can pass it to is less and less as more and more of the population is immune. Okay, here's another one, which is, I'm going to paraphrase this into something slightly less, I'm just going to paraphrase it. Are there different flu strain or flu vaccines out this year?
The flu?
The influenza vaccine. So somebody seems to think that there is a different, that there are more than one different types of flu shots available this year, and some may have broader or narrower coverage for different flu strains.
That is, to my knowledge, that's not the case. The flu vaccines, I think they've all converted now to quadrivalent. So what that is 2 strains of the influenza A and 2 strains of influenza B. They might be referring to the flu zone, the people that are older, I think older than 60 or 65, need to get a higher dose of the flu, a double concentration of the flu vaccine, to generate that immune response. But in terms of the actual strains, they're compatible from vaccine to vaccine. There is also flu mist out there that they've brought back after a hiatus of about a year or two. That is also available, which is attenuated nasal flu vaccine.
So the answer for the chief is that because he's old, he got a different vaccine. Is that what you're saying?
I can't speak to, can't speak to that.
I
No,
think,
so the assertion is that that depending on where you go, whether it's Publix, Walgreens, or wherever else, you might be given a trivalent versus a quadrivalent vaccine. I'm not aware of that. Are you?
I think they've moved away from the trivalents just a year or two ago, and I think there should be at this point quadrivalent, all of them. But
Okay, but a relatively young, healthy person is best served by a quadrivalent vaccine, correct?
yes, yes.
Yes. Cool. All right. Next is there any science? Well, first of all, I'm sorry. It's after 5 o'clock. Do you have a few more minutes for us, or do you have to go?
No, I'm okay.
Okay. There's only a couple more questions, and we'll say at this point, if you have any more questions that you've been saving, put them in now, or forever hold your peace. So yeah, Chief says that's what this old guy was told.
All that is just a higher dose of the same vaccine, essentially.
There you go.
that's a 65 and up thing, though.
Yeah, it's 65. Thank you.
Yeah. He's not 65 and up.
Well, I don't know, maybe. So says the bald guy to the other bald guy. So next one is there any science supporting eventual recovery of the long hauler? This particular clinician cared for one recently, and it was a devastating story. The family seemed to be prolonging the patient's life without a hope of recovery. So that sounds like a pretty tragic story. I have not seen much in terms of recovery on the long hauler stuff, except for there was the one case series that showed the 60 and 90-day persistence of symptoms, where it was, big number, like 50% still having respiratory distress or shortness of breath at 60 or 90 days, and 40% still having chest discomfort. So I haven't seen anything more concrete than that series. Have you?
No. And again, this is sort of you have to keep in mind, we've only been at this for 6 months. Some of these have been persistent beyond that time frame. So I think there's a lot more to learn. But to your point, most of these persistent symptoms have included, and I don't have that study in front of me, but I think the number one symptom was fatigue, but there were things like chills and dyspnea. So again, those long-term consequences, the sequelae, the potential scarring from the lungs for those that may have they've recovered from severe COVID, are huge issues that people have to deal with. Things that even the small stuff like the loss of smell and taste, that's a sort of a common symptom with COVID. That earlier studies did show that 90% recovered within 4 weeks, I believe. But subsequent studies are showing that some are even lasting longer, and with some even having permanent loss. So again, some of these symptom sequelae are for the long haul, unfortunately.
Yeah, I heard of one person who got his sense of taste back for like salad and things like that, but couldn't taste beer.
Right.
That sounds just sort of tragic, doesn't it? Enough to make you not want it. So listen, the last one we have here, and I can probably answer this rather than putting you on the spot with this. And it says, with the governor lifting restrictions, are you predicting a large jump in cases? So I would say that even before the governor lifted restrictions, based on the shapes of those curves I showed before and based on the experience in other places, I think that there is, even without that piece of the puzzle, there is a strong possibility, and certainly people like Dr. Fauci and Dr. Osterholm are also saying this, that they think there's a strong possibility that we will have another spike in cases sometime this fall. I think it's important to emphasize that nothing has really changed. We've covered the therapeutics and the vaccine landscape today, but nowhere today did you hear about a miracle drug or a miracle vaccine that's ready now that makes this not a dangerous infection to get. And so because of that, nothing's changed in terms of the prevention guidance. We know how to keep from getting this. It's hygiene, PPE, and distancing. And none of that has changed at this point. Every action is going to have a reaction, whether that's schools opening and putting people back in classrooms, or bars reopening. I think we all know what happens in the bar when you're face to face with somebody and it's loud and you've had a couple drinks, the voices go up, and people get closer to each other. So I think that each one of those will likely have an impact. I do think it's worth mentioning, and I think you've seen the county message on this as well, that the Pinellas County local mask ordinance is still in effect. The phase 3 from the governor does not impact that. And there are still some restrictions in terms of restaurant capacity, I believe, that are also part of the local ordinance that are still in effect. So while this will potentially open up some things, some of those major strategies that have been in effect so far are still going to be in effect for some time. And I don't think anything has particularly changed as to how we can prevent this. Did I say anything wrong there, Dr. Cho, or does that sound like about right?
No, I agree with you. I know Fauci and some of the other federal experts have talked about that seasonality aspect. Obviously, with Florida being warmer, it's less predictable. What we see generally up north, more so in the winters, is that people congregate more, and if you're more indoors, you have that higher likelihood of spreading any respiratory virus. That's why we do see that uptick traditionally, more so in the north. So hopefully they're incorrect and we won't see that second wave, but I think we do need to do everything and that we can to, number one, prevent it and be ready for it. Number two, be prepared for it.
Thanks. Okay, Jasmine, this last one is for you to keep me honest so I don't say something wrong. And the question is, are P100 still allowed or what's the story at this point?
So, yes. You can wear your P100 or your N95.
It's clinician's choice right now, correct?
Between those two things, yes, P100 or N95.
Right.
The medical control directive came out that you guys have 60 days to choose between P100 and N95, and then we'll decide at that point based on supply if you guys will go back to P100 or you'll still be able to keep choosing. But it's to give you everybody a little break in the heat and everything like that. So
cool. All right, so I'll try to sum up here. One, we're still seeing patients with COVID. I'll note I got surprised by one last week, so even when we're not surprised or when we're not expecting it, keep wearing your PPE, get your antibody testing while it's available if you'd like to do so. There's no hidden agenda on that. It is just an additional piece of information for you and your risk management as an individual. In terms of treatment, steroids are good if you need ventilatory support. Remdesivir makes you get better faster, but is mostly good in not so severe infections. Convalescent plasma, the monoclonal antibodies, hydroxychloroquine, Pepcid, and Kaletra, et cetera, are all still jury's out. No definite on most of those, although plasma and the antibody look promising at this point. As far as the vaccines go, 4 are in phase 3. It does appear they're following the usual vaccine development strategy, just at an accelerated timeline. So it looks like no safety shortcuts are being taken at this point. And I am reassured to see the pharmaceutical companies saying that they will hold to that in determining when to release one. The 4 in phase 3, at least 2 of them require severe refrigeration, which is going to be a very significant logistical challenge for us. You as the individual clinician need to start educating yourself about these vaccines and whether or not you're willing to take one yourself. Getting the vaccine will not necessarily make you stop having to wear PPE right away, but the sooner we get the biggest slice of the population immune, the sooner that day comes. So it is definitely related. What did I miss, Jasmine? Anything? Those are the major points, I think, right?
no, I do think we have to bounce back to the Salumedrol thing since this has come up, because this will be a question that will go on. So right now, we are still pandemic condition yellow. So if you have a COPD or asthma patient, you're going to treat them with Salumedrol. But if you have a suspected COVID patient, at this point, we are still withholding Salumedrol. Is that correct?
Correct.
Okay. And if there is any change in that, then we will put something out.
Stand by one. Okay. And with that, I think we'll go ahead and wrap up out of respect for Dr. Cho's time. I really appreciate you taking the time. I know you're incredibly busy. I'll tell you, you have single-handedly garnered one of the biggest audiences we've had, like a rock star. We really appreciate you sharing your knowledge and wisdom with us and your perspective on all of this. It's been quite a long road for us, so we appreciate your leadership and support during it.
Thank you. And I really appreciate how you present data and you back it up with all the studies and give us quick summaries. You definitely got a lot of information out to us very quickly. I really appreciate you taking the time to be here.
Thank you for saying that, and I appreciate the invitation. Thank you, and please let me know if you need anything.
Thanks, Dr. Cho. Stay safe out there, everybody.
Done.